Yep, thanks, Q. Good morning, everyone. So welcome to the ENT Masterclass. So I'll take you through sort of deep neck space infections, which is something that's that we deal with on a daily or a weekly basis, depending on the size of your hospital and the catchment area. And hopefully, by the end of it, you'll be a bit more familiar with the classification system, maybe some of the anatomy that's involved in the neck spaces, and more importantly, how patients present, how we investigate them and treat them. And I'll give you some of the hints that I've learned over the years in regards to patients presenting with sort of abscesses and infections in the deep fascial planes. Hopefully, a lot of it will be a reinforcement for you guys, and I'm sure a lot of it will be very familiar. So we'll start off with why this topic is important. Now, if somebody that presents with a deep neck space infection, if you don't treat them, the likelihood is they'll die. Yep. And the mortality rate before antibiotics, before we had sort of technology, is quite high. You're looking at upwards of 50%. Yep. Even with the antibiotics that we've got and the technology in terms of imaging, our expertise in managing them, even then there is a significant mortality rate associated with this. And the list that's up there is, I've come across every complication there. So from airway obstruction to mediastinitis, CNS complications, multi-organ failure, IJV thrombosis, hemorrhage, osteomyelitis, and I've come across a couple of deaths as well. So with experience, as you guys get a bit more senior, you will encounter a lot of these complications. And the whole object is not to get to that stage. Now, if you look at the neck spaces, this is probably the best classification system that I've come across, and you just divide it up into the spaces that are above the hyoid, below the hyoid, and the spaces that encompass the whole of the entire neck. So the ones highlighted in red are the ones that we're sort of more familiar with, and these are ones that we encounter regularly. So submandibular space, parapharyngeal space, peritonsillar, and retropharyngeal space. So I'll go through a lot of these with clinical examples. Now, the thing about neck spaces is think of it as potential spaces, but it's not, a walled-off space. These can communicate with each other. So if you think of infection that's related to an infected tooth, which can affect the submandibular space, that infection can then get into the masticator space, into the parapharyngeal space, carotid sheath, retropharyngeal space, and obviously, that's within the neck, and it can go upwards into the cranium and down into the chest. So if you think of the spaces as spaces that can communicate with each other, so one space, one sort of infection in one space can lead to problem elsewhere. So my first take-home message for you guys is anatomy is key. So learn the neck anatomy well, the spaces well, because ultimately we'll be operating in some of these people, and you want to make sure that the outcome is positive. So I'll go through the first case, which is something that most of you will be familiar with, which is a young lady, 24-year-old, who presents with sore throat, odynophagia. Her voice sounds as if she's got a hot potato in her mouth, and she's got fever. The diagnosis is pretty straightforward. So this is a complication of tonsillitis, and it's a peritonsillar abscess. So often with these, how do we manage these? Do we necessarily need to admit them if they're well? These are often young people, so if they're well, without any features of sepsis, do you necessarily need to admit them? Do they need to give them IV fluids? Do they need IV antibiotics? Do you give them steroids? These are all questions that I suppose you ask yourself when you see them. So my usual way of managing these patients is you don't necessarily have to admit them, because if they're fit and well, if they've got no systemic unwellness, then incise and drain them, and then send them home with some oral antibiotics. If they are a little bit unwell, then giving them a shot of dexamethasone usually reduces the edema, and as a result can reduce the pain, and there's plenty of evidence to support that. Whether you use a needle to aspirate them or incise and drain them, that's your choice, I suppose. But I prefer incision and drainage, because that way you've created a route for the abscess to drain. In children, I sometimes do a hot tonsillectomy, because luckily peritonsil abscesses aren't that common in children, but if you do encounter them, they won't let you, put a needle in their mouth, often when they're that young. So, and if you take them to theatre, it just makes more sense just to remove the tonsil and drain the abscess that way. Now, the second one is a 5-year-old boy who I saw years ago, who was under the medical team. He'd been with them for a few days with recent sore throat, and he was having, although the sore throat was better, he was still spiking temperatures, and more importantly, he wasn't really moving his neck. So he didn't have a visible neck swelling. He was on broad-spectrum antibiotics, and I think I was on call, so they rang me. I said, look, can you arrange a CT scan of his neck with contrast, which they did. My take-home message, the second one, and this is in children and adults, is if you see a child that's not moving its neck, even if they appear well, there's something isn't right. It's not usual for children not to move their neck. So, consider doing a CT scan. And I've picked up quite a few, retropharyngeal abscesses this way. Often they come with sore throat, that episode has settled down, they've got something, sepsis has gone deeper into the fascial planes, and although they look well, there is something isn't quite right, because they've got to often have a walled off abscess. So this was this little boy. So as you can see here, so this is a CT scan, and you can see in the retropharyngeal space, we've got this big sort of lucent area. Yep. And this isn't this child, but if you were to do a lateral neck film, and this is what you would show. Now you can see that the airway is narrowed, so that's the pharyngeal airway. And if you look at the lateral film, you can see it goes sort of further down. So that's the retropharyngeal space. Now the retropharyngeal space starts at the skull base at the top, and then it goes down to level of T1, T2. The anterior border is the buccopharyngeal fascia. Now that's the middle layer of the deep cervical fascia, and the buccopharyngeal fascia encompasses, or it circles the pharynx. Behind is the alar fascia. That's one of the divisions of the deep cervical fascia. So you've got retropharyngeal fascia, so prevertebral fascia, and then the alar fascia. So this is the posterior border. And as I mentioned, the top is the skull base, the lower one, it goes down to T1, T2. And it often contains retropharyngeal lymph nodes. So if you look at the etiology or the pathophysiology of retropharyngeal abscesses, majority of them are in children, so below the age of 6. And in fact, 50% of those occur in the first year of your life, between 6 to 12 months of age. The way that children present is different to the way that adults present. So children will, they'll just be irritable, poor intake, and often they won't move their neck. They may be drooling, which is obviously a worrying sign. Whereas adults, sore throat, painful swallowing, they might have a nasal sort of twang to their voice, and sometimes, it might have gone beyond the early phase, and they might have respiratory distress, airway obstruction, and you might even see swelling in the posterior or the lateral pharyngeal wall. Now, after the age of 6, the retropharyngeal nodes start to atrophy, so that's why you don't see it in adults. So in children, this is a suppurative process within the lymph nodes in the retropharyngeal space. And the source of infection can be often from sinuses, nasopharynx, adenoids, whereas in adults, it's often from trauma, such as sort of patients who undergo panendoscopy, biopsies, and also it can be, as you sort of mentioned earlier, it can come from adjoining other spaces. The key issues in dealing with retropharyngeal abscesses is, the airway protection is the key. Because if the abscess bursts, particularly in children, and if that goes into the lungs, that carries a really high mortality. So you've got pus in your lungs, and that's quite serious. So at the time when you decide to operate on them, you want to make that clear to the anaesthetist, and that you have to make sure that the anaesthetist is very experienced, because the way they intubate may change. Yeah. So because they're always worried about sort of bursting retropharyngeal abscesses. The other key thing is broad spectrum antibiotics, and be wary of immunocompromised patients. So children who've got the oncology patients particularly, so leukemia or lymphoma patients. And in terms of the drainage, there's two ways of doing this. One is you can go transorally, or you can go through the neck, and that depends on your expertise and where the abscess is. If it's all pointing inside the pharynx, then it makes sense to go transorally. Now, the third one is a 35-year-old lady who I saw with fever, sore throat, painful swallowing, and trismus. There was a sort of a palpable, visible, mild swelling in the submandibular and the retromandibular space. So she was treated with IV antibiotics for 24 hours, no improvement. Yep. So, what do you do? Imaging-wise, the gold standard, if you suspect someone has a deep neck space collection or sepsis, is CT scan with contrast. Yep. So that's the gold standard. Forget ultrasound scan. You can't tell if someone's got a retropharyngeal abscess or a deep a parapharyngeal abscess on an ultrasound scan, no matter how good they are. So that's the gold standard. So this is the patient I described earlier. So you can see that there's a lot of edema, but more importantly, what you can tell on the scan is where the abscess is, so the anatomical location of the abscess. But also, if you look here, this is a multi-loculated abscess. You've got one loculation there, another one, and it extends, out into the neck. Yeah. So that's really key, because if you have to operate on this patient, you want to know where the loculations is. You want to make sure that you try and break down all the loculations so that they get better quicker. Now, the parapharyngeal abscess is a space. It's described as an inverted pyramid, where the superior aspect is the skull base. So it's just when you just imagine you're sitting at the lower extent, which is the apex of the hyoid. So when you're looking up, so you've got the skull base, you've got posteriorly, you've got prevertebral fascia. Medially, you've got the buccopharyngeal fascia, or the pharynx. Medially, that's what you've got. Posteriorly, prevertebral fascia, and laterally, you have the pterygoid muscle, followed by the mandible, and then the deep lobe of the parotid. Yeah. And anteriorly, you've got the pterygomandibular ligament. Yeah. So that's the space you're looking at, and it's quite a long space. So this is the space you're looking at here. So the purple here is the lateral border. The medial border is this green line, which is the buccopharyngeal fascia, and the tonsillar space is here. So you can imagine if you've got a peritonsillar abscess, it can spread into the parapharyngeal abscess that way. And then if you've got a abscess within this cavity, then it can spread into the masticator space or the submandibular space. Yeah? So it's quite a long space. Now, the important thing about the space is there's two compartments. So this is on an axial CT scan, and this is the space behind the masticator space here. and it's lateral to the pharynx, and it's deep to the parotid space here. So in terms of the two compartments, you've got a pre-styloid and a post-styloid space. In the pre-styloid space, these are the contents. You've got a bit of fatty tissue, lymph nodes. You've got deep lobe of the parotid. Whereas in the post-styloid, you've got the major vessels and the lower cranial nerves. You also got sympathetic chain along with lymph nodes. So if you have abscess sitting around big vessels, one of the complications is that they can rupture. And obviously, this compartment, as I mentioned earlier, communicates with various other spaces. The causes of parapharyngeal abscesses can be anything from adenoiditis, tonsillitis, dental infection, from sort of infective parotitis, middle ear infection. I have seen 2 patients over the last few years who've developed parapharyngeal abscess from acute mastoiditis, and also extension from other spaces. The key thing about the parapharyngeal, it's particularly if the abscess is really high up, it can be quite difficult to get to. So if you've got a small abscess, so 2.5 centimeter, I think adopting a more conservative approach is absolutely fine, with the caveat that if they get no better with 24, 48 hours of antibiotics, then you may want to rescan them and then think about surgery. The other caveat is if there's an infection with a gas-forming organism, that's quite serious, and you need to be a lot more proactive. There is some evidence that if they have got lots of edema, maybe not a well-formed abscess, and if the child is sort of unwell and they're not getting better, even if you open up the space and put a drain in, they get better quicker. So if you open up the neck and you don't necessarily see lots of pus gushing out, just by opening the fascial planes and putting a drain in, the recovery is a lot quicker. So this is a patient that treated a while back with a retropharyngeal abscess, but you can see, this just looks horrible. These are gas-forming organisms, and we took this patient to theatre and operated, and they got better a lot quicker. So this is how it looks on the scan. And in terms of the approach, my preference is transcervical. If you drain parapharyngeal abscesses through the mouth, you often need to remove the tonsil as well. So bear that in mind. The other thing about draining neck abscesses, whether it's submandibular or parapharyngeal abscess, is just be aware that you don't damage the marginal mandibular nerve, particularly in children. The anatomy is quite distorted, so go fairly low. Now, the fourth case is a 54-year-old lady who I saw, I think about a year ago or so, unwell, painful swallowing, drooling, difficulty breathing to some extent, although she wasn't in extremis. She had swelling in the submental and bilateral submandibular region. It was more so on the left, and she had a temperature, and she was just unwell. She had sepsis. And this is what her neck looked like. So you can see there's a visible swelling on the left submandibular region, but all this area, it's all red and inflamed, which extends down onto the skin towards the chest. And this is, when you got her to open her mouth, this is all she could do, So she's got some trismus. But if you look at the floor of the mouth, it's all edematous. So, and in fact, if you tried to get a view of the oropharynx, you could see that the tongue at the back had pushed up slightly. So the diagnosis here is fairly obvious. It's, I don't know if most of you have come across these patients, but this is Ludwig's angina. So this is not a true abscess, but more a cellulitis of the sublingual and submandibular space. So the submandibular space, if you get edema, you get swelling on the, visibly in the anterior neck, in the submandibular area and the submental area, but also that space can lift the posterior tongue it can elevate it, so you could obstruct that way. And often, when you drain these abscesses, not often you don't get pus, but you get more like a serosanguinous fluid when you incise into the fascial planes. Majority of them are caused by dental infection, but also I think this lady, she had infection of the left submandibular salivary gland, and also you can get it from trauma or lymphadenitis. Mortality is still about 8%. So this is a life-threatening infection. So this was the same lady. You can see she had a CT of her neck with contrast, and you can see there's lots of edema. There's little pockets of gas and fluid-filled spaces. So I think the first operation was we went in. We're probably a little bit more conservative. So she went to ITU, got intubated. We took her to theatre, drained the abscess, and then she went back to ITU. Needed some inotropic support. The airway was obviously safe. We didn't decide to do a tracheostomy. That's the other option that you've got. So we sort of gave her about 48 hours with antibiotics, initial drainage. She got a little bit better, but the neck was still swollen. So we rescanned her, and then we went back and we did a lot more radical debridement and left lots of drains in, and she did get better. She was in ITU for about a week. Yeah. So management-wise, it's quite difficult to intubate them. So you'll have to liaise with the anaesthetist. So airway management again. So I think she had a awake fiber optic intubation. We then sort of scanned her once the air was safe. She had antibiotics, drained her, and then I think about day 5 we did a tracheostomy, and I think about 5 or 6 days later we decannulated her. Her bacteriology grew a combination of gram-positive cocci and bacilli. Yep. My other take-home message for you guys is, if you see anybody with a submandibular, submental abscess, look at the teeth, because 85% of these infections are from the teeth. So be vigilant. So this was a patient I saw with a submandibular abscess, which you can see here. So left submandibular abscess. But if you look closely, there's a tract that leads up to one of the molar teeth. I don't know if you can appreciate that on there, but you can see something there. And then if you then flip it onto the bony windows, you can see there's a little bit of cortical loss. And then I arranged an OPG for her, and you can see there's a bit of a loosened area in the, I think it's the second molar, or between the first and second molar here. And that looks a bit mottled. So, because the thing is, if you just drain the abscess, you haven't really dealt with the primary problem. So you'll need one of your dental colleagues to come and remove the tooth as well and deal with that. In terms of pathogens, so majority of them are gram-positive, sort of strep, staph species. You do get gram-negative, so often they're polymicrobial. You can get a combination of aerobes and anaerobes, and particularly if they've had lots of antibiotics, when you send pus off to the lab, it's often sterile as well. Now, this is another patient I saw with, I think this was probably about 6 months ago, with Lemierre syndrome, and that's septic thrombophlebitis of the IJV. And that's often due to a bacteria, Fusobacterium necrophorum. It's just, the name just sounds horrible. And people used to die from this. Treatment's really aggressive with antibiotics. You may need to drain if there's a abscess that is significant, bit like this one here. So you can see that the IJV is completely occluded with a abscess, probably within the, I think this was within the carotid sheath. In terms of anticoagulation, there's no real consensus. It depends where you work. We tend to discuss with our hematologists, and they'll often say, look, anticoagulate in the 3 months. If you look at the literature, it's divided. It's 50-50. There's no real, even if you left them without anticoagulation, a lot of the times the IJV does sort of cannulate and open up after about 3 or 4 months. Mortality with Lemierre syndrome is about 5%. So, again, they need treating aggressively. So this is the same patient. You can see, that's the IJV here. You can see there's an abscess here, so after drainage, it's remarkable actually. After you drain them, they do get better within 24 hours. They're so much better, and that's just due to draining the abscess and reducing the septic insult. The other, it's not just the Lemire with sort of necrophorum, but also strep milleri can give you septic emboli. So this is a patient who was in ITU for a while because there was multiple septic emboli in the lungs. And again, a lot broad spectrum antibiotics, ITU inotropic support. This patient got better with time. This was a little boy that I saw, I think it was about 2 years ago, who had sort of sore throat, fever, and wasn't looking well. Went to A&E, and he had a big sort of swelling in the sort of the parapharyngeal area. So the tonsil was medialized, but whoever saw him could see that this was pulsating. So it got referred to us in Leeds, and we sort of got the child scanned, and you can see here, this is the aneurysm of the internal carotid artery. So from sepsis within the parapharyngeal space, this is developed into a sort of aneurysm, and that could rupture any time. Luckily, we got the interventional radiologist to coil it and embolize it. And in fact, I saw the child probably 6 months later, and he was absolutely fine. But that's another complication of tonsillitis. I have seen a number of necrotizing fasciitis over the years as well. This is another quite serious infection with high mortality. Immunocompromised patients, so diabetics, or those who've had radiotherapy for head and neck cancer. So if they come in with sepsis, take it extremely seriously. They get unwell so quickly, and the infection spread so quickly along the fascial planes that surgery is you have to be extremely radical from the outset. It's not a cosmetic surgery, put it that way. Yeah. This is another patient I saw who unfortunately died, who came under the medics again he had a beard, so they didn't notice his neck swelling, but he was type 1 diabetic, sugars all over the place. He was really unwell, and he'd been under the medical team for about 2 days, and somebody noticed when they lifted his beard that he had a swelling there. And by the time we got him to theatre, he refused to have anything done initially, but by the time we got him to theatre, he was already in multi-organ failure, and in fact he died, despite draining the infection. So airway management, this was a patient I saw probably about 3 months ago. So what you can see, this was another diabetic chap who was unwell. In fact, when I saw him in clinic 2 months later, he was back to normal, but he had no recollection of being in hospital. He was with us for about 14 days. Yeah? So came in with a quinsy, drained on the ward, got a little bit better, but just wasn't right. I saw him on the ward round, and he was completely delirious. By the time we got him down to theatre, the anaesthetist looked at him and said, look, he was already in multi-organ failure. His Usenes had deteriorated. He was mentally obtunded. So we took him to ITU, optimized him for about 6 hours, and brought him to theatre. Now, what he had was multi-space involvement of his previously drained quinsy. So this is the epiglottis. Yeah? So he's got an abscess there, and this is within the sort of peritonsillar abscess, and also heading out into the parapharyngeal abscess. So the anaesthetists were, it was quite a challenge for them. So again, airway management. He had awake fiber optic intubation, and then once the air was secure, we sort of re-scanned him, took him down to theatre, re-scanned him, and then he had his surgery. So take-home message: it's all about the airway with deep neck space infection. So liaise with the appropriate staff in the hospital. So it's usually your anaesthetist. You may want to liaise with the ITU people, because you also have to have a plan after you've drained or after you operate on these patients. So take-home message 7, mentioned earlier: elderly, diabetics, immunosuppressed patients do really badly, and be aggressive. Yeah? And also think about what the organism is. So hopefully this is just a summary slide. Yeah? So we talked about treatment algorithm, systematic approach, airway, breathing, circulation, early diagnosis, broad spectrum antibiotics, and the whole aim of dealing with these patients is to prevent complications. Yeah. So that's my last take-home message. Assess early, carefully, diagnose early, and then treat them aggressively. Yeah. Again, this is what you're trying to avoid. Okay, that's all from me. Yeah. Any questions?